Hey Insta family, Happy New Year! How is everybody in 2023? Let's kickstart another year, and hopefully this year is a little bit of a different start to last year. They seem to be getting better and better since beginning of 2020, if I recall. I hope you guys have had a good Christmas and New Year. Set yourself some goals. So while everyone's jumping on, I want to just reflect on something that has just kind of blown my mind a little bit, actually. I just finished a little meditation session with my 8-year-old, something that we do most nights of the week. It's one of the strategies I use to try and get her off to sleep, but it is something that is actually really helpful for my mental health and well-being as well. So I use the Calm app. I'm not sure if you guys know the Calm app. I'm sure there are heaps of others, but I've always just really resonated with the Calm app, and there are little daily meditations. They go for about 10 minutes. They're really good. And they often have a great message. And this particular one tonight really resonated with me because it was all about stopping for a moment, taking stock of what it is you are trying to become, who you are, your identity. And the way of tapping into that is, instead of being pressured to look outward for the solution, actually just taking a moment, stepping away from the discomfort and the challenges of the external world and stimulus, and actually going in. And the reason that it really resonated with me tonight was because on New Year's Eve, my husband had booked me in for an amazing retreat for one at Bodhi Day Spa. I know, very, very indulgent for me. And it was a combination of a body scrub, lymphatic massage, full body massage, and a facial. So it went for like 3 hours. Now, there is never a time in my life where I have 3 hours just to myself. If I'm not working in the business, I'm working on the business. If I'm not doing that, then I am being mama, or I'm being wife, or I'm being friend, or I'm being daughter. I'm sort of doing the juggle, right? And so there's very little time in my world for just me time, apart from the time when I'm at the gym at 4:30 in the morning. But the focus there is very different. It's to, smash out the the gym routine and nail the sets and the reps and the weights and all of those sorts of things. Goal. There's never free space. And so in this 3 hours that I had at this retreat, I actually had that time to go completely in. And being in that moment of sublime comfort, the creative juices were flowing, and the innovations were coming to me, and the ideas and the inspiration. And I have some superb things that I am going to implement in 2023. I cannot share them with you right now, but what I can say is that yesterday, I sat down with a very special person in my life, and we spent about 90 minutes brainstorming on something that we're going to bring to you together in 2023. So I'm just going to leave you with that. I'm just going to drop that little bomb with you to think about, but I'm super excited that it is something that's going to add even more value to what you guys have going on in your lives and in your world and the connection that we have. So just giving you that little bit of tidbit, but it was really cool that the meditation tonight actually resonated with that. I'm also listening to a great audio book at the moment on Audible. It's by a guy called David Goggins. It's not everybody's cup of tea, I've got to tell you, but it's mine. He has written a book called Never Finished. It's his second book. I read his first book. Well, I listened to his first book, and it was totally inspiring to me. I'm not going to say anything more other than to say, look, if you like Audible, if you like listening to Audible books, this is certainly one that I would recommend. As I said, it's not everybody's cup of tea, but it's certainly, there's a few F-bombs that are dropped, but that is the style of the author. And I was inspired by his first book, I have been equally inspired by his story and what has come out of his story and his difficulties in life and what he's actually been able to achieve as a result of those difficulties. So anyway, the same message came in his Audible interview today about sometimes in moments of comfort, you can go within and find all this incredible creative inspiration and innovation. So again, I don't know, the universe is just sending me all of these messages and I've really tapped into that. And so I have some incredible stuff coming your way this year. But I think I've gabbled on long enough. There's enough of you online now, I think, that we can get stuck into our first Q&A for 2023. Super excited. I feel a bit reinvigorated by some time off. I hope you guys do as well. So drop the questions into the comments. Remember, keep them as generic as you can. Let's not have your life story. That way we can give as generic answers that might be applicable for more than one person. And I will try, although I am somewhat verbose, I will try to keep things as straightforward, as simple as I can. I have had 2 questions DM'd through to me. So the first question was around low-dose stimulation, FETs, thoughts on inositol. I'll come back to that in a second, GGM2P, all right? Okay, so the first question, someone was asking me about why do we do low-dose stimulation in a frozen embryo transfer cycle? What is the purpose of that? And you know what? It's a really great question because it is important for you guys to understand the method to our madness. So when we do a frozen embryo transfer cycle, what we are trying to do is mimic the environment that an embryo would normally arrive into the endometrial cavity. So normally fertilization happens in the tube. It takes about 4 or 5 days to make its way down the tube where it's growing and compounding and increasing in cell number. And by about day 5, blastocyst stage, it has arrived in the endometrium. So if we do it in a fresh embryo transfer cycle, obviously we have the follicles there that have been stimulated when we've done the egg collection, and then we've provided you often with some progesterone support after we've triggered those follicles. That's one way of doing it. The other way in a frozen embryo transfer cycle is to either mimic the cycle by giving you the the estrogen first, growing up the lining and giving you the progesterone such that we're transferring the embryo into the endometrium at the stage that would be that window of implantation. Or we actually kind of encourage your body to do its own natural cycle. Now, we can just do a natural cycle. So we can just say, hey, let your body generate a follicle. When we come to the time when you're about to ovulate, either monitor you really intensely for sort of days on end to determine exactly when you ovulate, and then count forward by 6 days and put the embryo back. Or we can actually fabricate the ovulation so we know exactly when you ovulate, and that's when we give you a trigger, and then count 6 days forward and put the embryo back. Or we can actually give you just a little bit of gentle stimulation at the beginning of your cycle, a little bit of recombinant FSH, so gonal F or Puragon, and just stimulate you to release 1 or even 2 follicles that produce the estrogen that then stimulates the lining, and then we trigger those follicles to then start to produce the progesterone, and then count forward 6 days and put the embryo back. That's called a low-dose stimulation FET cycle. Where the benefit of stimulating that follicle is, there's new research that actually demonstrates that women who have a corpus luteum, a follicle that's been ovulated, present in a frozen embryo transfer cycle, they're far less likely to get preeclampsia. So we think that there are other chemicals that are being produced in that process of ovulating that are going to help reduce your chances of getting preeclampsia later on in the pregnancy. That corpus luteum is really, really important. And so a lot of us are moving back towards either low-dose stimulation or natural cycle FET so that we've got that corpus luteum present. So that was a really, really good question, and actually quite timely with the release of new information around stimulated FET cycles. Thanks for that question. Another question that came through to me in a DM, and I will come back to the question that was posted, but a question that came through around what is the role of stress in irregular cycles and PCOS? Good thinking. Okay, So, irregular cycles can be due to any number of things. The most common thing that we see is polycystic ovarian syndrome, which is partly a genetic condition. So we've got this sort of disordered signaling from the brain, and also combined with metabolic syndromes, often insulin resistance and overweight. So that's one cause. Where could stress be involved in that? Well, I suppose with not being able to control weight, we sometimes find, and I find this, and I don't know if you guys are the same, but I have a large percentage of women who lean into emotional eating. I'm one of them. When I'm stressed, I'll go for the high fat, high sugar foods. That doesn't serve someone who has insulin resistance. And so I suppose from that perspective, it could play a role in increasing irregular cycles in the context of PCOS. However, the most common place that stress potentially plays a role is in something called functional hypothalamic amenorrhea, or disordered ovulation as a result of hypothalamus, abnormal signaling. So the hypothalamus, which helps to control the gonadotrophin releasing hormone, which stimulates the pituitary to release FSH and LH. It's a little bit out of whack due to other neurotransmitters and a couple of chemicals that can inhibit that axis is cortisol, adrenaline, and noradrenaline, which all happen as part of the stress response. So without going into a whole heap of detail, that's probably the place where stress has the biggest role, is in hypothalamic suppression and disordered ovulation. And there is some research that cognitive behavioural therapy can be helpful in those with functional hypothalamic amenorrhea in actually kickstarting cycles again. So we know there's a role. We don't really know how much of an impact it has, but absolutely we know that stress plays a role. So good question. Okay, let me see. Now, there were these other questions. Guys, so many familiar faces or names that I'm seeing on here. Lovely to see you guys all on. Here we go. Thoughts on inositol in the management of PCOS. Okay. I don't know this intimately. However, I know that there are two different isomers of inositol. One is myo-inositol and one is chiro-inositol. It's the myo-inositol that is most likely to act like metformin as an insulin sensitizer. There is not a lot of evidence on it. There's not a lot of publications on it. It is thought, however, to mechanistically act to be an insulin sensitizer, and so biologically it makes sense that if metformin helps to improve pregnancy rates in the context of ovulation induction and insulin resistance with PCOS, then myo-inositol will do the same. Has there been any research on that? Very little good quality evidence. Where its advantage may be over metformin is reduced side effects. So my go-to would always be metformin. With proper introduction of metformin, and it's important to talk to your specialist about it, you can overcome the side effects, the nausea, the seediness, the bowel hurry. But if you are still struggling and it would mean, hey, I'm not going to take metformin at all, then perhaps the introduction of myo-inositol is an alternative, but it would never be my first line because the evidence just isn't there. Okay, hopefully that was helpful. I know it is found in some supplements. All right, any other? Okay, Peter Marie 9. What is ICSI and how is it different to IVF? Great question. Okay, so at the beginning of a cycle, an assisted reproduction cycle, we do something called controlled ovarian hyperstimulation. So that's where we give you the same hormone that your brain produces to release one egg, but lots of eggs all at once. And that hyperstimulation is kind of like hitting a nail with a sledgehammer. And we use the same chemical, recombinant FSH, but in much higher doses, kind of opening up the gate more so more of those follicles can come through and be recruited to hyperstimulation. And that usually takes around about 2 weeks. That's the first half of the cycle. Then we go collect those eggs. That's the egg collection. And then we have to inseminate the eggs. And there's 2 ways that we can inseminate them. The first way is called IVF, in vitro fertilization. That's where we put each egg into its own little droplet and we surround each egg by about 100,000 sperm and the best one wins. So there's still some natural selection that happens there. However, in some populations, generally with men with very low sperm count, you don't have enough. You don't have 100,000 sperm, or perhaps the motility is really low, and so you don't have enough motile sperm to surround each egg. You therefore do something called ICSI, intracytoplasmic sperm injection, where you put all the sperm in a little dish, you have a look under the microscope, you find a good looking one that is moving, you immobilize it by putting a little kink in its tail, you suck it into a little pipette, and then you micro inject it into the cytoplasm within the egg itself. So you're overcoming the several steps of fertilization where there might have been a problem. Another population where you'd use ICSI would be perhaps someone has failed fertilization in a previous IVF cycle. Wow, there you go. You just found out why they weren't falling pregnant and you therefore move on to ICSI. So ICSI is a really good way of overcoming severe male factor infertility or failed fertilization. We sometimes use it in genetic testing cycles as well to improve the accuracy of testing. But there are specific criteria for which ICSI should be used. But good question. Such a good question. Thanks for asking it. Okay. Hopefully that was a helpful answer for you. Do I recommend resting someone Sashur? Did I say that right? Do you recommend resting for a few days after an embryo transfer, or can you fly travel? Loaded question. Okay. There's no value in resting after an embryo transfer. There's no evidence to say we should wrap you in cotton wool after you've had an embryo transfer. But that is very different to hopping on a plane and flying off somewhere. So I guess it depends in the context when you're having an embryo transfer. If you have had a fresh IVF cycle, your estrogen is going to be through the roof, really high. That combined with gynecological surgery and hopping on a plane, you're a sitting duck for getting a clot in the legs or the lungs. So I don't like my patients to hop on a plane after they've had an embryo transfer. It also depends on how long you're going away for. So if you're going away for weeks at a time, maybe you're going overseas, for example, I have no way of monitoring you. So I can't do your blood tests. If you start having bleeding, I can't do an ultrasound. I can't get you to get blood tests done. I can't change your level of supports. So my advice, and it's just my thoughts, it's just my opinion, but if you are committing to doing IVF, you really should hang around. You really should. So that enables us to help you if anything starts to go a little bit pear-shaped. And you might be in a foreign place or a foreign country that makes it really difficult for us to help manage you. So I know this whole process is really interruptive on life. I get that. So many men and women have put their lives completely on hold in order to do this, and I completely understand that. But there are often reasons why we say don't travel, and they would probably be a couple of them. But to be honest, it's a complete negotiation that you have with your fertility specialist. So sit down and have the open and honest conversation with them. It'd be so much better if you did. Okay, hopefully that's helpful. Rouse 5774. Dr. T, is there such a thing as estrogen dominance when taking HRT? Oh, that's a really good question, Rouse. I would like to say to you that there's no such thing as estrogen and progesterone dominance, because at different times in your cycle, you're going to have higher levels of estrogen than progesterone and vice versa. So you are expected to have varying levels of estrogen dominance and progesterone dominance. What we find, however, is when women are going through the menopausal transition, so they're in the perimenopausal period, they will have times where their estrogen is much, much higher, i.e. estrogen dominance. And that might be because in their last hurrah, they've released 2 and 3 follicles at the same time. And so that instead of having a peak estradiol of 1,000, it'll be 2,000 or 3,000. And you can get moodiness, and you can get breast tenderness, and you can get menstrual migraines that have kicked in again, whereas you haven't had them for years at a time. And equally, you can have dives in those estrogen levels, and you get symptoms consistent with hypoestrogenism. So the hot flushes, the mood changes, the sleeplessness, the skin crawling, yada, 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 vaginal dryness, all of that. So you can get this waxing and waning symptomatology. You can also have a really poor second half of the cycle if the follicle that's producing the estrogen is old, which is generally what happens around menopause. And so the progesterone levels in the second half of the cycle are really crap. And so you have a relative luteal phase deficiency. So would I necessarily say that's a dominance and a sort of estrogen and progesterone dominance that needs treating? No. You need to treat your symptoms. And if it's that you've got dysfunctional bleeding, if it's that you've got waxing and waning hypoestrogenic symptoms, then taking a combined menopause hormone therapy may help regulate your cycles and may help to manage all of your symptoms. But it doesn't really control the estrogen progesterone dominance that might be happening underneath as you are transitioning through that perimenopausal time. So yes and no. Perhaps it's just more of an explanation to how people utilize that term. I think a lot of people use that term quite loosely without really understanding what they're referring to. So hopefully that's a little bit more helpful to you. Okay. Oh, any more questions? This is great, guys. What a nice array of questions we've had to kick off the year. Hopefully I covered everything that was sent through to me. If anyone is online and there were any other questions, I did do a quick check before I jumped on, but I cannot see any other questions here. So we might wrap it up for tonight. But thanks for jumping on. I am thinking that my big innovation, my inspiration, my idea, my creative juices and ideas, I'm probably going to reveal to you towards the end of January. We're going to look at a February kickoff for what we're planning. And so I will definitely keep you in the loop. So keep jumping on a Tuesday night. Here's a couple more questions. 2 more questions and then we'll call it quits. Women's nutrition. Why do some IVF doctors not investigate endo early on in the process? Had a few clients. Why do they not investigate endo? Well, the diagnosis of endometriosis is laparoscopic. Sometimes, this is a big question. I don't know that I can answer it easily. Certain levels of investigations can be done and they're based on symptoms. Without proceeding to laparoscopy. And some fertility treatments are enough to overcome, say, mild disease, right? And so submitting someone to a laparoscopy which may or may not identify anything can take them off track, can be burdensome from a financial point of view, can be time consuming if they have to wait for surgical spots, and is not without risk. Just because you diagnose someone with endometriosis plus or minus treatment doesn't necessarily mean that you're going to improve their fertility outcomes. In saying that, it's very dependent on the individual, right? So you've got to think about what else is going on in their gynecological history. Are they symptomatic of it? Is that what needs to be treated? Is there anything going on with the bloke that needs to be taken into account? So I think that I can't tell you what other IVF doctors do other than to say it is always in the back of my mind, because 45% of women who present with infertility have endometriosis. It's a fair proportion of them. Do we always need to go in laparoscopically? Not necessarily, because some of the fertility treatments that we offer is enough to overcome. So in a nutshell, without spending an entire question and answer series talking about it, I think that might just give you some food for thought, hopefully. And I kind of figured you hadn't finished. So That's okay. And Peter Marie, how long does a full cycle of IVF take and how available do you need to be? A full IVF cycle. Well, it really kind of mimics what happens in a month, right? So you get your 2 weeks of stimulation, you get your egg collection done around the time you would normally ovulate, then you wait 5 days for the blastocyst to mature, and then you transfer it, and then you got to wait 2 weeks for your pregnancy test. So that really is the whole cycle, right through until your pregnancy test, which would normally be about the same time as you testing for a pregnancy for spontaneous pregnancy. So you got to think about that. So really, you've only got, 12 opportunities a year to fall pregnant. You can't do an IVF cycle off the back of an IVF cycle in most cases. So you've really only got like 6 chances per year, but that's super burdensome. I don't know anyone who's done 6 IVF cycles a year. That's full on. How available do you need to be? Absolutely need to be available. You should plan to be in town for the entirety of your cycle. So it's hard for people who do FIFO, for example, really hard for women who do FIFO to undergo IVF because we need you here for monitoring, blood tests and ultrasounds. Sometimes we want you to be having ultrasounds in-house to get better accuracy. And really, as I have said before, it's not ideal to be traveling after you have had your transfer because we can offer very little if you're out and about. So you should plan to be here. Okay, it really burdensome. All right, love this Tuesday night info. Well done, doctor. Oh, my pleasure. My pleasure. Have you travel account Europe? Oh, look, you've sucked me in. Have you had many patients fall pregnant between IVF cycles naturally? Yes, we all have. There wouldn't be a fertility specialist out there that has not had a patient fall pregnant between IVF cycles. It happens. God forbid a spontaneous pregnancy should happen, but it is. How common is it for the first round of IVF to fail? Very common. On average, Australian couples will go through 2.1 IVF cycles to have their first pregnancy. So it is common for the first one not to work. Okay, Life of Brit, good to see you back. I will save this live. It will be here on my Instagram page. You can come back and have a look. My pleasure, everybody. Thank you so much for jumping on tonight. And I will see you next Tuesday. And I'll maybe drop a little bit more information about what my plan is come February. So excited. Okay, guys. Have a great night. Bye.